We'll invite all the panelists on stage. Dr. T. Nandakumar,
Dr. Karuna, Dr. Arunachalam sir, on stage please.
he is a practicing pediatrician from Trichy. He's completed his MBBS from MMC and DCH from Stanley. Life member of IAP, NNF and IMA. Served as secretary for IAP Trichy and was the organizing secretary of South Neocon. Received the Active Pediatrician Award in 2017 and from 2018 he's been actively creating awareness about lifestyle among doctors and public. So he is going to be talking about pediatric obesity. This will be like a question answer session. So the first question to you, sir. Obesity is commonly believed to happen because of junk food. Is that really true? Are children obese only because of junk food? What do you feel, sir?
Junk foods are one of the reasons for obesity, but there are many. Obesity is a complex disease, so many factors are the reasons for obesity. Babies born to obese moms, GDM, low birth weight babies, they are prone for obesity. The small for gestational age infants, that is the babies born below 2.5 kilo birth weight or less than 1.5 kg birth weight, they have low adipocytes and they have low skeletal mass tissue, and also they have low pancreatic tissue. So these children, when they are exposed to excessive nutrition, they are prone for hyperinsulin secretion, resulting in obesity, metabolic syndrome in the later life. So that is the Barker's hypothesis, which is proposed by Dr. in 1990. So like that, the large for gestational age infants, that is the babies born to GDM mothers, they increased delivery of glucose and macronutrients are going to those children, which make them obese, and they have high insulin secretion. Also, they have high insulin secretion. They have high leptin levels. Also, these children are more prone for obesity. And those children, those who lack breastfeeding and early bottle feeding, also they are prone for obesity. And those children on junk food, they have increased chance of becoming obese. Lack of physical activity and excess screen time and less sleep also is a reason for obesity. So these are all the multiple factors, risk factors for obesity. And at the individual levels, there are many factors like medication. Some children are on antipsychotics or antidepressants and many other steroids. Those children are also prone for obesity. And yes.
So moving on to the second question, sir. So we are seeing a lot of obese children in our practice, but there's a confusion who we have to classify as obese. Is there any criteria to define obesity, sir?
Yes, definitely we have some criteria. Because we divide obesity into exogenous and endogenous. Exogenous obesity is due to environmental factors like food style, lifestyle issues, all those things. And endogenous obesity due to secondary causes, which is less than 10% of the causes, like endocrine obesity or other reasons, secondary causes for obesity. So, yes.
So moving on to the next question, sir. How can we measure obesity in children? We usually measure obesity in adults with BMI. Is it practically possible in children?
Definitely, BMI is the most used tool for measuring nutritionally obese children, and we all know that BMI, the BMI, this is ratio is weight in kg by height in meter square. This is the most common formula used for measuring obesity. We can also plot it in the percentile charts provided by the IAP guidelines. Which is more than 2 standard deviation, it's called as obesity. Or if it is more than 1 standard deviation, it is overweight. So this is 23rd adult equivalent, we call it as overweight, and 27th adult equivalent is obesity. This is a perfect definition for describing children as obese. And also we also have the waist circumference thing. We have to measure the waist at the umbilical cord level, and if it is more than 70th percentile, we call them as obese. This is the latest IAP guidelines we have got it. We also know the comorbidities are associated with obesity like hypertension, dyslipidemia, non-alcoholic fatty liver disease and type 2 diabetes mellitus. This non-alcoholic fatty liver disease, I want to stress more because we are seeing a lot of children, obese children, nearly 40% of them are having this entity. We have to screen them properly to understand this problem, this major issue, because it is the most leading cause of liver transplantation in the world. The criteria for metabolic syndrome, we all know that the abdominal obesity, that is the waist circumference more than the 90th percentile for age, and with more than two of the following, that is the triglycerides more than 150 milligram per DL, or the HDL cholesterol less than 40, or fasting blood sugars more than 100, or systolic BP more than 130, or diastolic BP more than 85. We call them as children with metabolic syndrome. The prevalence of metabolic syndrome is nearly 13.6% in overweight and nearly 46.4% in obese Indian children aged 10 to 18 years.
So there's been a lot of talk about balanced diet. Even sir was demonstrating my plate for a diabetes child. Is it possible in children? Is a balanced diet possible in children, sir?
Yes. We follow this traffic light diet plan. That is, we advise children not to take this in the red zone. That is the candy, cookies, cakes, chips, pastries, sugary beverages, processed meat. All this come under red. And the yellow, we can take it in moderation. Whole grains, dairy, eggs, chicken, fish, lean meat can be taken in moderation, and all vegetables and low sugar foods can be consumed. And also, this is the my plate technique we used to suggest to parents. That is, one fourth of the plate should be fruits and 1/4 should be vegetables. The other 1/4 can be grains and protein and dairy. Because we don't restrict carbohydrate in a major way, we make children to eat at least 50% of the calorie requirement from carbohydrates, because carbohydrates are necessary for children, because insulin is a growth promoting hormone. So insulin is necessary for overall growth and physical development. And we stress on this essential amino acids, because most of the children are not being given proper protein rich diet. For example, an adolescent weighing 50 kgs, they require nearly 50 grams of proteins per day. That is 1 gram per kg per day. So we have to provide them with essential amino acids, because essential amino acids are necessary for the growth and development, and also for the hormonal functions, synthesis of hormones, and other reproductive functions, all those things, because essential amino acids are very much necessary for the children. And also, we have to give them proper essential fatty acids. Like essential amino acids, essential fatty acids cannot be produced by our body. We need from external sources. So these are all the omega-3 and omega-6 rich products we have to give them. And the ratio should be maintained 1:4, because majority of our Indian children are getting more of omega-6 and not getting omega-3. So if the ratio is kept as 1:4, they will have adequate all the essential amino acids necessary for the fatty acids necessary for the body functions. And also, we suggest these complex carbohydrates in the form of fruits and vegetables, because they are necessary for the probiotic and the gut microbiota, because the gut microbiota is very, very important for the digestive purposes, and also for the providing insulin sensitivity and other important factors. Our gut is innervated by the enteric nervous system, which connects with the brain. So the mood, memory, all those things, it is necessary. We need to feed them with the right probiotics, so that they will have some intellectual capacity, better intellectual and learning memory capacity better. Now also, this whole grains I already told, carbohydrates are required for children for their growth and this thing. So we advise parents to give at least 40 to 50% of caloric requirement from carbohydrates.
What is the role of physical activity and sleep in pediatric obesity, sir? Can you elaborate?
Definitely, physical activity is a must, because we encourage children to have at least 60 minutes of physical activity per day, because physical activity not only improves the general well-being, also necessary for the BDNF, that is a brain-derived neurotropic factor, and neurogenesis happens, learning memory improves, and also it improves the autophagy and many other things, beta oxidation, all those happens. Obese children, definitely physical activity makes a very, very big role and essential role. And sleep is also important, because in this Netflix era, most of the children are not able to sleep properly. They are awake until midnight, and they are not having proper sleep. It also causes obesity and have problems with memory and other things. So we ask parents to make the children sleep at least 8 to 10 hours in a day, so which will help them preventing obesity. Pradeep? I think, any other questions? So
I think that's an elaborate talk, sir. So we'll come back to you later at the end with the questions,
okay,
sir.
Okay.
So previously, yeah. So Dr. Arunachalam, sir, he is an associate professor of anesthesia from Government Mohan Kumaramangalam Medical College, Salem. He is a promoter of Sri Suraksha Hospital from Salem. He is a family physician, diet and lifestyle coach at Jean and Jenny Diet Clinic from Salem. He is currently pursuing PhD at Vinayaga Missions University, Salem, on effectiveness of low carbohydrate diet in women with PCOS. And his area of special interest is he's a practitioner and preacher of LCHF for the past 8 years. So can we go on to the presentation, sir? So the previous presentation, sir.
At the outset, I wish to thank the organizers for giving me this wonderful opportunity, and our beloved chairperson for giving a nice introduction about me. I am going to answer some questions on polycystic ovary syndrome and diet. And I'll add a disclaimer here before our chairperson settles. I am not a gynecologist or a reproductive medicine specialist, so I am going to talk on these topics. So that's a disclaimer I want to leave before I start.
So we often hear PCOS is linked to hormonal imbalance. So what is the root cause for PCOS?
Okay, so PCOS is an interesting topic if you start reading. And this is the female physiology which we all read in our Ganong and gynac books, which we see the female physiology. Actually, what happens is we read physiology in silos, like we first read metabolic physiology, then we go to gynac physiology. So that's where the disconnect happens. But actually what the physiology which we have to know is this one. So we just know, we have to understand that the female physiology is influenced by the hormones in the metabolic pathway. Like insulin and leptin have a very big role in deciding the status of female physiology. This is the point I want to drive home today. Of course, our gynac books, short textbook of gynecology mentions the action of leptin in the role of leptin in female physiology. But what even most of the books fail to mention is the role of insulin in female physiology. So that's where we miss the bus. And see, from morning we have been talking all these cycles. We are eating a lot of high carbs that leads to high circulating insulin. So under the influence of insulin, more fats get stored in the adipose tissue. That leads to insulin resistance. So the body tries to compensate by secreting more insulin. So we have more circulating insulin in the form of hyperinsulinemia. That causes more appetite. And again we start eating the same high carbs. This vicious cycle sets in. And the hyperinsulinemia again causes deposition of more fats in the adipose tissue. To understand PCOS, we have to understand this thing. See, insulin resistance has got two arms. On your left side is the insulin not functioning arm. Insulin not functioning properly, that leads to high blood glucose and diabetes. But insulin resistance has got another arm, that is the hyperinsulinemia arm. You have to understand that whenever I say insulin resistance, in some cells of the body the insulin is not acting. That's one end, that causes diabetes. And the circulating insulin is more. Certain cells are still sensitive to insulin. So what happens? In those cells, the hyperinsulinemia causes a over effect of insulin. That happens in the ovary. So ovary tissue is usually sensitive to insulin. Even presence of insulin resistance in other areas, there the hyperinsulinemia causes overstimulation of the ovary, causing polycystic ovaries. What happens is insulin goes and blocks the conversion of androgen to estrogen. So the estrogen level goes up, goes down, and androgen level goes up, and PCOD results. So we have to understand that PCOD, we all know PCOD is an endocrine disorder. We also have to understand that PCOS is a metabolic disorder, and I will say more pointedly, PCOS is a nutritional disorder of eating over carbohydrate and over circulating insulin.
So all the PCOS patient has to do is to lose weight, sir. Can she do that just by eating less and exercising more?
Okay, so that's an interesting question. That's what we see. So most of gynecologists send to me patients saying that these women are obese. Once you reduce weight, the PCOS will go down. Of course, once you reduce weight, the PCOS will go down. But that is not just by reducing weight. Actually, the diet what we are going to give, the diet which I am going to recommend, is going to reduce the weight and also alter the hormonal imbalance happening in the ovary. And this question places a unique, another side question should be there. See, what about suppose you all know, practicing gynecologists and family physicians will know, like a lot of PCOS women have lean phenotype. nearly 30 to 40% of women, Indian women particularly those in Tamil Nadu, we have a lean phenotype PCOS. If you look at them, they will be very thin, but still they will have PCOS, they won't have cycles. So what to do in them? In them we can't go and ask them to reduce weight, is it not? So to understand that, we will just see what is happening there in metabolism and in PCOS. So this is the caloric centric theory. I think morning there was a debate on this high calorie, low calorie debate. So what the thing which we all think that there is a calculator in the body, and calorie intake minus calorie spent. The body calculates the calorie balance, and that causes a change in weight. If you have a positive calorie balance, we grow in weight. If there is a negative calorie balance, we lose weight. And what the physiology and biochemistry teaches is a big no there. Okay. So this equation, the body doesn't work by this equation. Actually, body works by the equation which I mentioned there. Instead of caloric centric theory, what we learn now is you have to come to hormonal centric theory, where we have to talk about more particularly insulin centric theory. So when the insulin levels are high, when the circulating insulin level in your body is high, as I mentioned previously, you will get more hunger. So automatically you will go and eat more. When the insulin level goes up, the basal metabolic rate itself comes down. So the calories spent will be less. So automatically the calorie balance will go up. Automatically we all grow obese. So see how the equation changes in the face of a high circulating insulin level. So what happens when the insulin relatively reduces? This is not type 1 I am talking about. Insulin level normalizes. From a high level it normalizes. It comes to low normal level. Automatically the hunger goes down, the calorie intake comes down, and the BMR increases, the calorie spent increases. And we have one more factor coming into the equation, that is calorie wasted. That is the ketones. When the insulin levels are low, the body goes into a state of nutritional ketosis. That is a unique situation where you can easily, suppose you have more calories to, suppose I'm having say 1000 calories. I have spent only 500 calories. Rest of 500 calories I can excrete out. If it is in the form of ketones, it comes out through the breath, it comes out in the urine. So you can waste calories, is it not? You can eat as much as possible. That's why in LCHF we say there is a safety tap available there. Even though you take more calories, when they are converted to ketone, I can just breathe it out or just pass it out in the urine. So that is also lessened. So calorie balance automatically comes down, and that causes a reduction in weight.
So what diet would you advise for a PCOS patient?
So what diet you advise for PCOS? PCOS, as I told, it is a state of high insulin level. If you check PCOS, we are not doing the test commonly. If you go and check fasting insulin level in all your patients, that will be relatively high. The normal value they say is less than 6 units, but usually all our PCOS women have a high insulin state. What it is caused by? It is caused by overeating of carbohydrates. So what is the antidote? Just reduce the carbohydrates. So the low carbohydrate diet is the only recommended diet for PCOS. Here again when I say low carbohydrate, it's a relative term. So normally we in South Indian diet will be eating around 200 to 600 grams of carbohydrate per day. So standard textbooks mention low carbohydrate diet as moderate low carbohydrate diet is 130 to 225. Less than 130 is low carbohydrate diet, and very low carbohydrate diet is 20 to 50 gram. And diabetic associations, morning Dr. Hariharan spoke about this. They mentioned less than 150 gram per day, and in paleo diet we have 50 gram per day, and keto diet we have 20 gram per day. So you can just choose the amount of carbohydrate which the patient can tolerate, which the patient can accept, and depending upon the goals you can set the carbohydrate range and then recommend a diet. And this is a low carbohydrate diet plate model. This they would have shown previously. This is the one which I usually recommend to the general population. Suppose somebody comes and says me, sir, low carb diet is okay, but I can't go for paleo or keto. The top one is the high carbohydrate diet model. So all our South Indian plates will be like that. 30 nariya soru, ஓரமாக கொஞ்சம் காய். அதுதான் நம்மளுடைய ஸ்டாண்டர்ட் சவுத் இண்டியன் மெனு. That is a meals, full meals which we say. Though we say full meals, the meals is full of rice only. So what the thing which I suggest is, you can start from the, you can start from the 12 o'clock position. Start with the vegetables. Have 2 vegetables. And then go to the fat portion. For vegetarians, you can add paneer. For non-vegetarians, you can add meat or eggs. And add a fat topping in the form of coconut, ghee, curd or cheese. And then come to carbohydrates, little portion. For example, somebody is eating 4 idlis per day, 4 idlis at a time. If they start with the vegetable and eat an egg, automatically the idli will come down to 1. At least this is a starting point for a PCOS patient. Somebody who's facing infertility may not get okay with this, but otherwise women will start ovulating if they are able to sustain on this diet for at least for 3 months. I am saying about the plate at every meal, that is vegetable at each meal, an egg at each meal, and then the remaining portion go for the rice.
So we are running short of time, sir. Can you conclude briefly? Any studies to say that LCHF works for PCOD?
Okay, just conclude quickly. So I have done some studies. This is an observation study which I just presented in the Family Medicine Conference. A case series of 3 patients. And then this is a comparison of, as I told, obese and lean PCOS. I did a study at my clinic. This is a data taken from my clinic. We showed that insulin resistance is there similarly in both obese and lean PCOS. Both may be different phenotypically, but metabolically both are same. This was a study. And this is a study of studies. I have done a scoping review of all the studies which have been published on diet and PCOS. It has shown that all the studies show that low carb diet has got an excellent result in PCOS.
So what about the role of diet in male infertility, sir? Does it improve the fertility parameters?
Of course, the male counterpart also suffer from the high carb thing. This chart I showed previously. As I told, insulin resistance has got 2 arms. When the insulin doesn't function properly, the endothelial cells dilate less readily because of the less amount of nitric oxide. So that causes erectile dysfunction. That is the first indicator of insulin resistance in men. And the hyperinsulinemia arm causes obesity, and that leads to low testosterone and low sperm production. So obviously both these arms can be bettered with low carb diet. So low carb diet works for male infertility also.
Thank you, sir. And we'll go on to the final session. So can I have the Karuna ma'am's CV? So ma'am, Karuna ma'am is from Well Home Clinic, and she's giving wholesome care with holistic approach involving family counseling, adolescent counseling. She has held various posts in IMA. She was the chairman of CGP in 2019, chairman for the Women's Wing at 2024. She was the state secretary for Women Doctors Wing in 2011, and she has won multiple awards from National IMA. She is the director of Well Home Foundation, and she aims to move forward for a small contribution towards our national strength and wellness. So please go on to the slide, sir.
Thank you.
It's a very important topic, nutrition in pregnancy. So ma'am, nutrition in the antenatal period is vital. Why are we so much concerned about that?
See, the nutrition is vital for everybody, but it gains importance because we have the pregnant and the lactating women who are the vulnerable in the society, who have the micronutrient deficiencies. Of course, macronutrients are there, but the micronutrient deficiencies are there with all the women, and especially we are with the pregnant and the lactating women. Why we need to improve that? So here comes the concern. It is not with the men or with the younger children or the elders, because these young women, they are going to give the highest birth rates in the world, which contribute about 20%, and the 27 million pregnancies are happening every year, who contribute to the highest proportion of the children less than 5 years. We know India has the youngest youth population, and the less than 5 years is also much more in India. So this health is directly related to the women health of the adolescent age and the younger reproductive age. If it is, what is the impact of that? So when the younger generation is not fed well, that results in the 30% incidence of the IUGR and 26% of the low birth weight, and also 21% prevalence of the preterm. We know the preterm can occur anywhere from 28 or from 24 to 36 weeks. So that causes a lot of burden for the society and for the parents, we have heard. So when in an NICU, if the baby is born as a preterm, if the baby has to be in ICU with the sepsis, and if on a ventilator, they have to spend around 15,000, 20,000, that goes in lakhs when they have to stay for months together. So how much ever care we give, incubator we give, no incubator is equal to the mother's womb, which takes care of all the things. So we want to prolong the pregnancy inside the uterus as much as possible. Next question.
Nowadays we hear about this term preconception nutritional counseling. Is it so much necessary?
Yeah. Preconception counseling is very important because we know since morning we have been hearing that good nutrition is an important component of the healthy lifestyle and in turn the healthy baby. It's very important time of the fetal development is the first 9 weeks of the pregnancy, where the organs are being formed and they undergo rapid development. Many women, they do not even realize, even the family members, many of the doctors also miss that they are in the early pregnancy. Unless we have it at the back of the mind, any woman of a reproductive age, at least in our country who is married, is likely to be pregnant. So that should be in the back of the mind. That only makes us know that she is pregnant, and we will not give unwanted drugs or antibiotics or like that. So all of us miss our early pregnancy. So we don't have time to teach the people that this is what you have to take. So this makes us, therefore it is prudent to make one's lifestyle and the nutritional changes several months before the conception occurs. So the best time to review the nutrition status and to make appropriate changes is prior to conception. And so here against the pre-pregnancy counseling. Because why? Becoming healthy before becoming pregnant is important. Our pre-pregnancy weight directly influences the birth weight. Even if the patient has been an underweight woman, even if she gains a normal weight of 12 to 14 kgs during the pregnancy period, the outcome of that is not equal to the women having the normal weight. And overweight women, we always know the baby is going to be big, and the mother also has problems like hypertension and the diabetes. So pre-pregnancy nutrition, what we should do, what one can eat can play an important role in the mother's health and also in the developing fetus. Many women don't eat a well-balanced diet before pregnancy. What is happening? Many do not afford, they cannot afford to have the nutritional demands for the pregnancy. But on the other side, we have people, rich people, who have in plenty, but they choose the wrong food. Anywhere we are caught. So what we do in our clinic, so we ask them to fill up this form. So we give this form and we ask them to fill. At least we will know. Because we cannot be saying everything, this is what you have to take. So everything should be tailor-made according to the patient's work and their cultural habits and the physical activity. So we ask them to take this. So they fill that form. This is how one of the girls are filled. So she's an engineering working in the company. She's staying at Chennai. They stay in the PG. So sad, all the people stay as a paying guest and they don't get enough and the right food at the right time, and they don't have the access to cook also. Of course, they do not know cooking and they do not enter the kitchen. This is the status of the girls. And for other children who are with the family...
Sorry to interrupt, we are running short of time, ma'am.
And for other children who are with the family, they also do not have the balanced diet, so they do not add the vegetables. So what we do? So all of us know this. This is what you need to take. So we get from the systems. But they do not know the name. So what we thought, we'll have a thing and we write the names of that so that at least they will know what all is available, what they have to take, what the lentils and what the millets are. Even if they know, then we have a thing that we measure that and we show them. So we have the purpose, everything we have, and we measure and show that. And after that, we give them for 5 weeks, this is a daily routine we ask them today, because whenever we ask them the routine, what is that? They get up at 9 o'clock, 8 o'clock, 10 o'clock, they don't have food. When they get out of the house without having food, whatever is available on the way, like bhaji, bonda, chips, puffs, Everything is a craving for them. But at the same time, if they have your food at the home and they get out of the house, nothing is going to be seen. Nothing gets into their mind. So we ask them to get up early, have all those things, routine things. And so we say, "Ninga kolambu rasam pori ellam saapidanuma, idella saapidum, inda urulakkelangu vendakkai ellam saapidum." This is what we made for the diabetic people. But of late I found this is appropriate for everybody. And for 8 months old baby to 80 years old, diabetic or hypertensive or obesity, whatever it is, this holds good. But they do not know how to cook. So we did that menu. For 5 weeks we made the menu. So morning like that we made for first week, second week, third week, fourth week and fifth week, because some months have 5 weeks. And so like that we used to take and give. So they have this, and we find a phenomenal change in their weight and their periods. They're getting over and they become fertile also. And we have the chutney, because when they make it, we ask them chutney, enna chutney ma, kara chutney, something and all, they will say illa chumma thair potu saapta chakra. So we thought we'll make a chutney. This is the color. Husbands say குழந்தைகளை ஏமாத்துறதுக்காக இந்த கலர் போட்டிருக்கோம், but the basis is the same. So இங்க எல்லாம் இந்த மாதிரி. So what we make is the chutney we make, the fiber is there. So it contains everything, fiber, proteins, vitamins, everything is there. So அதனால வந்து நம்ம இட்லி, நான் நினைப்பேன் இட்லி, நம்ம முன்னோர்கள் வந்து இட்லி, தோசை, சட்னி, சாம்பார் நம்ம they have designed. நம்ம சாம்பாரை சட்னி மட்டும் சும்மா சாப்பிட முடியாது, which contains the carbohydrate, vitamins, minerals. அதுக்கு we need a vehicle. That vehicle is idli or dosa or chapati or rice. So நம்ம என்ன பண்றோம், அந்த வெஹிக்கிள்க்கு இம்பார்ட்டன்ஸ் கொடுத்துட்டு காரம் புளிப்பு எல்லாம் அளவா போட்டுட்டு சட்னி நிறைய சாம்பார் நிறைய தொட்டு சாப்பிட்டு பழகணும் நம்ம. That is what. Next, sorry.
So is pregnancy and weight gain, is it a healthy partnership?
Yeah, this is the only place where the weight gain is encouraged. So in the first time people are happy, but at the same time they are anxious. So they have nausea, vomiting, giddiness. And the only thing, the supporting care they need from the family and in the working place. And here we cannot ask them to take this diet to take, because அவங்க சாப்பிட்றதே பெரிய விஷயம். அங்கே பக்கத்தில் போனாவே ஸ்மெல் வருது. ஸோ உங்களுக்கு என்ன பிடிக்குதோ சாப்பிடுங்க, பட் ப்ளீஸ் ட்ரை டு டேக் இட் ஹெல்தி அப்படின்னு சொல்லிடுவோம். அப்புறம் ஃபோலிக் ஆசிட் சப்ளிமெண்ட் இஸ் ஒன் திங் வெரி இம்பார்ட்டன்ட். ஸோ வி நோ தட் 11 to 14 kgs இந்த டைமில் வெயிட் வந்து நமக்கு ஏறுறது தான் ரைட்டு. அதனால ஃபர்ஸ்ட் செமஸ்டரில் 0 to 85 calories we need, second trimester 285 and third trimester 475 calories. The weight gain should not be confused with the obesity. நிறைய கேர்ள்ஸ் இப்போ வந்து they want இன்னும் வந்து 50 kg தாஜ்மஹால் தான் நான் மெயின்டைன் பண்ணுவேங்கிறாங்க நிறைய பேர். இப்போ ப்ரெக்னென்சி அப்போ அப்படி தான் இருப்பேன்னு சொன்னால் ரொம்ப கஷ்டம். ஸோ we ask them, please change to something else until the lactation. So this is the reason for the weight gain: placenta, amniotic fluid, breast, uterine mass, fat fluid. So this is the reason for the weight gain. So it is acceptable. All of us should agree with that. And from the second trimester on the cover, people they'll be somewhat comfortable. Vomiting illa, nausea illa, konja tiredness illa, giddiness illa. So anga dhaan naan solluvom, second trimester very important for the next coming generation. You have to be careful.
Shall we finish this, ma'am? Yeah. Nutrition during different periods of pregnancy, ma'am. Can you elaborate?
Yeah. So it is the second trimester where we need all the proteins, all the micronutrients. These are the importance. Iodine, choline, all important for the brain development, calcium, vitamins. One thing we should understand, the baby will take all the vitamins, vitals it wants from the mother. So it is the mother who is going to lose. But the baby, if she doesn't take enough calcium, the mother's bone will go for osteoporosis. And so this is what we say, for extra nutrients can be got from all these things. And the third trimester is one thing. Here we need to give the foods according to their needs, because they'll have the difficulty in sitting, walking, they'll have hemorrhoids. So depending upon the individual things, we will tailor-made the food accordingly, increase fiber or whatever it is like.
I think we'll finish it, sir.
We'll have this 1 minute, sir. This only one. Okay. This maybe we'll make. Breastfeeding is very important. It's not only for the baby, it's for the mother also. So it's not moving. I think
I will move.
Next question.
Yeah,
so we have to know that if they're going to breastfeed, now the latest studies have said that they'll have low risk for all these things. So this helps them, for the mother and also the parents in the family, to make the mother breastfeed. So we need the maternal counseling. Why the mothers find it very difficult? Because we need encouragement from the family. We need encouragement from the family to make them get breastfeed. That is very important. And one more thing, they, sir, on the nipple picture muttu potrீங்களா? So one of the reasons for them not getting the enough adequate milk is, we have come across that we need to examine the nipple in the antenatal period. So mothers want to feed the baby, the parents or everyone is willing, but when we see the nipple, either it be a flat nipple or it has got inverted nipple. That becomes one of the reasons for the breast to get enlarged, and they land up with the breast abscess where we need to put the IND. So around the second trimester, it is all the gynecologists should examine that the breast nipple is very well seen so that the baby can latch well. This will prevent the lactation difficulties.
Thank you, ma'am.
Thank you.
So we saw a big continuum right from pediatrics to the puberty period, and finally we culminated with pregnancy. So this is a cycle, and only if this mother is healthy, we can get a healthy baby. So thank you for listening. We'll end this session.
I request Dr. Pradeep sir to present the memento to Dr. Nandakumar. Now to Dr. Karuna, Arunachalam sir. To Karuna ma'am. Dr. Pradeep sir.
Next session. We are moving on to the next session, and all the Nalamdana participants, please wait till the end. All will get appreciation medal from our committee. Thank you.